Okay, here we go. Okay, Juan's got a question here. So question, when do we do the treatment with steroids or the splenectomy? Okay, remember, whenever there's an autoimmune hemolytic anemia, how do you treat all autoimmune diseases in general? Steroids and immunosuppression. So you start with steroids first. Steroids first. If the steroids fail, if they're insufficient for stopping it, then you do splenectomy next. Steroids first, then you're going to do splenectomy. Because that's where the antibodies are getting destroyed. The antibodies in the red cells are being eaten in the spleen. So we'll take the spleen out. Okay, make sense? Excellent. Once you got it, you got it. So for autoimmune diseases, steroids first. If they fail, we go to splenectomy. Because remember, I don't want to lose my spleen. I like my spleen. It protects me. So we don't want to do the splenectomy unless we really have to. If we have to, we have to. And then make sure you get vaccinations. Okay? All right, now let's compare the one that you're talking about, the autoimmune hemolytic anemia, to hereditary spherocytosis. They could be similar on the exam. Now, obviously, you're born with this. Your whole life, you have chronic mild hemolysis with spherocytes. Your whole life. Okay? Oh, another question, hold on. What does rituximab and it's going to attack the B cells and stop the antibodies. B cells make antibodies against the red cells. So if I immunosuppress you by knocking out your B cells, now you'll stop the antibodies and you'll stop the autoimmune. Okay? Good. I'm here for you guys. I want you to rock step 2. Remember, it's me and you against this dragon. We're going to slay this dragon, get our 260, and move on. Because that's the key. We got to do well on this exam. As a residency director, we want to see good step 2. Step 2 is management. It's treatment. Step 1 means you're smart. Step 1 means you're really smart. Doesn't mean you're a great doc. Step 2 is management. Right? So we want to see really good step 2 scores. So I'm here for you. You got any questions? I'll give you my email. Keep in touch. Because I want you to be successful. So let's tell the difference here. Hereditary spherocytosis, you have your whole life. You got it your whole life. Right? You have chronic mild hemolysis your whole life. You have spherocytes your whole life. Autoimmune, you're not born with it. Autoimmune, you get in your reproductive age, right? So this is a big clue. You had this your whole life. Your whole life, you've had episodes of jaundice. Your whole life, you've had a big spleen because you have a genetic defect in the spectrin. The spectrin, the red cell membrane protein, spectrin is broken. So I just remember, spherocytes, problem with spectrin. And again, it's kind of hard to see, but I think you could see no central pallor. Oh, this one definitely no central pallor. I think you can start seeing no central pallor. But John, this looks exactly like the other picture. Looks like the autoimmune. Looks like the IgG autoimmune one. So how am I going to tell these apart? They look the same. They both have spherocytes. All right, now let's talk about etiology. This is autosomal dominant, so 50% chance of giving this to your kids. It's due to a problem with spherocytes because spectrin is the scaffolding, the structure to hold the biconcave shape. To keep it a biconcave disc, I need this spectrin. Without spectrin, your cells become round. So they form a spear, they're no longer flexible, and since they're now round, they can't get through the spleen. So they get stuck in the spleen and destroyed. So notice, spherocytosis, you're going to get spherocytes and splenomegaly. Spherocytes and splenomegaly. But that's what happened in autoimmune. Autoimmune's the same. So we got to tell these apart. All right, now again, it's a chronic disorder. You tend to have a mild to moderate anemia. It's not usually severe. It's mild to moderate. You'll have splenomegaly your whole life. You'll have jaundice, episodes of jaundice your whole life. Now, if you suddenly get a severe anemia, like really low anemia, check the retic count. The retic count's low, check the bone marrow. It's going to be parvovirus B19 or folate deficiency. This sounds exactly like sickle cell. Just like sickle cell. Just like sickle cell. Just like sickle cell. Hemolytic anemia should have high retics. If the retic is low, look at the bone marrow for parvovirus and folate deficiency. Okay, so very important, just like sickle cell. The same thing can happen in sickle cell. Okay, good. Look for the low retics. Now, this is very testable in step 2. If they get right upper quadrant pain after a fatty meal, do an ultrasound of the gallbladder for pigmented gallstones. They get it early, they get it young, they get it common, because their whole life they have hemolysis, their entire life. So they're always going to get stones, always. Very testable. All right, now for diagnosis, we're going to see anemia. It's going to be normocytic, okay? So it's usually normal, or maybe slightly low, because these tend to be microspherocytes. Usually it's in the normal range on the exam. You're going to have hemolysis, so LDH is going to be elevated. Here's an important one. Here's an important one. Now, these cells are normal. They got normal hemoglobin. So if I ask you, what's the mean cell hemoglobin? Normal. Mean cell hemoglobin is normal. They're normal cells. They got hemoglobin. But they're smaller than normal. Less volume. So what happens to the mean cell hemoglobin concentration? The mean cell hemoglobin concentration is increased. It's more concentrated. It's more concentrated. So that's a really big clue here. Really big clue. Normal hemoglobin, increased concentration, because they're very small and they got the normal hemoglobin. But even better than that, well, bilirubin's up, retic count's up, but that's the same as anything. Better than that, you want to look for osmotic fragility. Look for osmotic fragility. Here it is. This is the best test. Best test for a spherocyte is increased osmotic fragility. Okay, so this is your best test, osmotic fragility. So I'll see the spherocytes and I'll look for increased osmotic fragility. But John, what's the best test for telling spherocytes due to hereditary from spherocytes due to autoimmune? Oh, the best test for differentiating would be a negative Coombs test. If it's positive, it's autoimmune. If it's negative, there's no antibodies. It's negative, it's not autoimmune. So for differentiating, Coombs. For telling that there's spherocytes, osmotic fragility. So best test for spherocytes, osmotic fragility. Best test for distinguishing the two causes of spherocytes is the Coombs test. If it's positive, it's autoimmune. If it's negative, it's hereditary. All right, now, how are we going to treat these patients? Well, number one, they need folate. Because their whole life, they're breaking down cells. They need folate. They're going to run out. Number two, cells are destroyed in the spleen. So if you want to stop the destruction, you got to remove the spleen. So if it's more severe, we will do a splenectomy. Splenectomy. Now, after splenectomy, the anemia gets better. But they have more spherocytes. Why are there more? Why are there more spherocytes? Because they're not being destroyed anymore. So you'll see more spherocytes. But it's okay. They have normal hemoglobin. They carry oxygen great. They do a good job. The problem is they were round and they were getting stuck in the spleen. That was the only problem. Okay? So let me repeat. Splenectomy makes the anemia better, but you'll have more spherocytes. Timothy has a question. Osmotic fragility only tells me spherocytes. So osmotic fragility is increased in both. Doesn't differentiate. Doesn't differentiate. They both have osmotic. Osmotic fragility means a spherocyte. That's what it means. Okay, so tell them apart. Differentiate. Coombs, 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 Coombs. Okay, good. All right, now, a couple more diseases and we're done with these hemolytic ones. We're almost done here. This one's kind of a hard one. Paroxysmal, so episodes of nocturnal at night hemoglobinuria. So episodes of hemolysis at night and you'll get hemoglobin in your urine. This is intravascular hemolysis. Now, by definition, this is a problem with the red cell membrane. It's a genetic problem with the membrane, so you'll get episodes of dark urine and venous thrombosis. This is what's going to kill them, venous thrombosis. So they get anemia and thrombosis, anemia and thrombosis, episodes of anemia and thrombosis. Now let me explain. Let me explain this one. Here is your sexy red cell. What's on the surface of your red cell? Well, there's an anchor protein called GPI. GPI, it's an inositol protein. It's inositol. GPI, the I is for inositol. GPI. That's on all your red cells and your white cells and your platelets. It's an anchor protein. It's going to hold other C8 binding protein. Do I have to know that one? Nah. It's going to anchor CD59. Do I have to know that one? Nah. CD59. But most importantly, let me type this one out, it's going to anchor CD55, also known as decay accelerating factor. John, do I have to know CD55? Oh yes, I typed it out for a reason. You need to know it. CD55 is decay accelerating factor. I remember like this. In America, the speed limit used to be 55. It's too slow. 55 is too slow. I want to accelerate. I want to go faster. I want to do 70, 80. 55 is too slow. So decay accelerating is the old speed limit. It's too slow. Sammy Hagar wrote a song called I Can't Drive 55. It's too slow. I want to accelerate. So this is the one I want you to know, because this is your protection. Always use protection. Complement gets activated in your blood all the time. I want complement to kill bacteria, but complement doesn't care. Complement is like a guy. It sees a membrane and it wants to poke a hole in it. It's that simple. See a bubble, I want to poke a hole in it. I'm a guy. Girls like, oh, the bubble's so cute. Guys like, pop. We just want to pop holes in things. So complement gets activated and it wants to punch a hole in the membrane. But I don't want it to kill me. I want complement, the MAC, the membrane attack complex, to kill bacteria, not me. So what is your protection? Your protection is DAF. DAF is going to inhibit complement. It's your protection. So listen closely. Every cell in your blood has to have protection. Your red cells have DAF, your white cells have DAF, and your platelets have DAF. Every cell in your blood needs DAF because it's protection. So this is what your blood looks like. Okay? You got these anchor proteins called GPI. They're holding on C8, CD59, CD55. CD55 is protecting your cells. Now, in a disease called paroxysmal nocturnal hemoglobinuria, this is an acquired disease. God forbid if you got a mutation in your stem cell in your bone marrow. God forbid. If you got a stem cell mutation in one of the stem cells and you knock out the gene in the stem cell called PIG-I, that's the name of the gene, sorry, PIG-A I should say, PIG-A gene, you'll get PNH. So again, let me repeat. It's a mutation in the PIG-A gene. Acquired. You get a mutation in your stem cell. Now look at this name. What does that I stand for? Inositol. What does the A stand for? Anchor protein. This is the gene that makes the GPI. It helps make it. So if you acquire a mutation in your stem cell in the PIG-A gene, well, when that stem cell makes new blood cells, they're missing GPI. Uh-oh. If my red cells and my white cells and my platelets from now on from that clone, if they're missing GPI, that means they don't have this. It's going to fall off. They don't have CD59. It's going to fall off. And they don't have CD55. Oh, no. You just lost protection against complement. So now at night, when you're sleeping, when you sleep, you don't breathe as deeply as you do when you're awake. You get a respiratory acidosis. Everyone does. Acidosis activates complement. So while you're sleeping at night, you activate your complement. When I activate the complement, the acidosis activates the complement, you get hemolysis at night while you're sleeping. So what happens in the morning? You wake up with anemia. It's a giveaway. What other disease do you know of? You go to sleep at night, everything is good. You wake up in the morning with anemia. It's a giveaway. And then when you get your tired butt over to the bathroom, Tasnova says, you're going to have red pee. Yep, you're going to have dark or red or pink urine because intravasculolysis makes hemoglobinuria, red pee. You can't miss this. You wake up with anemia and red pee. Something happened overnight. Something happened. You have anemia and red pee in the morning. Something happened overnight. Make sense? Makes sense. So let's look at the rest of these notes because I think you understand it now. It's an acquired mutation in the stem cell. Okay? So all cells are affected. Red cells, white cells, and platelets. That's why they're going to get clotting. Because when I damage a platelet, they thrombose. That's what they do. Okay? Yeah, any acidosis can do it. If you exercise and get a lactic acidosis, you will get an episode of hemolysis too. Any acidosis can do it. It's usually at night though when you're sleeping, but any acidosis can do it. Now let's read it together. It's all here. It's all written out for you in words. The red cell membrane defect is a defect in the GPI-linked proteins that were made by the PIG-A gene. PIG-A gene. These are the ones that are going to be missing. Now, without these, you have no protection against complement. Complement without GPI, no decay exciting factor. The red cells get attacked by complement and you get intravascular hemolysis. You got no protection. Now this is clonal stem cell disorder. So if I get a mutation in a stem cell, they could go on to develop aplastic anemia and they can get leukemia. So very important associations. When you have PNH, you must refer to a hematologist. You must refer to a hematologist because you are going to have a risk of anemia, aplastic type, and leukemia. They must follow this patient. All right, now a couple other important things here. The cells are more susceptible to lysis whenever there's an acidic environment. So that usually occurs when you're sleeping at night because of hypoventilation. But like you said, it could happen if you're exercising, you get a lactic acidosis. You get hemolysis from anything that gives you acidosis. Now, the symptoms are anemia in the morning, dark urine in the morning, haptoglobin will be low in the morning. But really important, that's not going to kill me. What's going to kill me is when you injure the platelets and you get thrombosis, major cause of death. Usually it's venous thrombosis. So hepatic vein thrombosis like Bud Chiari, that will kill you. You can get pulmonary emboli. It's usually venous thrombosis. That's what's going to kill you. Okay? All right. Now, again, the hemoglobinuria is usually seen in the morning because overnight is when you had the hemolysis while you were sleeping. Okay? So that's why it's in the morning. All right. Now, for diagnosis, since it's intravascular, as we mentioned earlier, haptoglobin's low, LDH is high, you'll see hemoglobinuria, and in a few days you'll see hemosideruria as well. Remember the hemosiderin after a couple days when you slough off those iron-rich proximal tubule cells? Yeah, you'll see it in a few days. Okay, good. All right, so all the intravascular ones look like that. Now, for diagnosis, in the old days, we used to screen with the sugar water test, and we used to confirm with the Ham's acidosis. These are no longer done. We haven't done them in my lab in about 15 years. We don't do this anymore. So again, screening, diagnosis, but not anymore. Not anymore. What do we do today? We do flow cytometry. So the gold standard is flow cytometry. What CD number will be missing? I can't drive. 55 will be negative. It'll be negative. And what was the other CD number? Do you remember the other CD number? CD 59 was another number there, wasn't it? CD 59 will be negative. I can't drive 55 or 59. They're too slow. Too slow. Remember, this was decay accelerating factor. It's missing. So looking for this DAF, CD55, is your test right now. But I got to be honest, it's not the best anymore. It's not the best anymore. Okay, it keeps getting better. The latest test is the flare assay. I know, I heard this on the exam recently. The flare assay. And I don't have to write this out because it's a really long name. It's fluorescent labeled. Hold on. I'm going to write out what it means. Flare assay. Fluorescent. Oh, I can't even spell fluorescent. Oh, it's U-O-R-E-S. I love it. I'm a doctor, but I can't spell doctor. Fluorescent labeled. Labeled. Okay. They use this bacterial product. Okay. Here's what it stands for. The flare assay is now the best. This is a fluorescent labeled bacterial product. It's from a bacteria. It's aerolysine. It's a lysine. It's a component of a bacteria because this will stick to GPI. That's what was missing, GPI. GPI was missing. So this is going to stick to GPI. So the flare assay is using this fluorescence to look for GPI. Right? Make sense? So the old days we used sugar water and acidosis. Wasn't good enough. Then we moved to flow cytometry, looking for CD5 and CD59. Much better. But what was even better? You're missing the PEG gene. You're missing GPI. Look for GPI with the flare assay. Okay? So let me repeat. On your exam, if the flare assay is there, this is the gold standard. At least it will be. Okay? It's a new test. It will be the gold standard. Okay? So they're starting to ask it on the exam. It's not in all labs yet, though. So again, if this is there, this is the best. Okay? Missing GPI. If GPI is missing, that's your best test. But if that's not a choice, then the answer is flow cytometry, looking for CD55 and CD59 missing. If that's not there, if they want to be evil, the old test is the sucrose test and the acidosis test. But again, those we haven't done those in 15 years. So I'm pretty sure this is the one they'll be looking for. But I've heard there's one question where this is there as well. If this is their flare assay is the best. Flare assay. Yep. If it's negative for GPI, that's your best assay. Because you're assaying for GPI. GPI is missing. If this stuff, this fluorescent doesn't stick, there's no GPI. Got it? All right, Tyler? All right, good stuff. Good stuff. I'm giving you the latest, greatest stuff. A lot of doctors don't even know about this flare assay, but it has been tested. It's brand new, and it will be the gold standard when enough labs get it. Right now, though, if I had to say what's the gold standard right now, gold standard is still flow cytometry because all labs have flow. But soon, flare will be the gold standard. Okay, and it will be the best answer on the exam, that's for sure. If it's there, pick it. If it's there, pick flare. All right, now very important, treatment, treatment, treatment. If there's a rapid episode of hemolysis, you can use prednisone. Prednisone can help because it stops inflammation. But the only cure that we know of, you got a bone marrow mutation. Your only cure, true cure, is a bone marrow transplant. Only true cure. Okay, but what if I don't have a donor? Okay, if you don't have a donor, a couple things we're going to need to do. Since you keep getting episodes of hemolysis and you're peeing out your iron, your hemoglobinuria, you're going to need some iron from time to time. You're definitely going to need folate from all the turnover. And you may need some transfusions. If you get a lot of hemolysis, you may need a transfusion if your hemoglobin gets low. Less than 8 or less, transfuse. All right, now, you're going to need anticoagulation when you start getting thrombosis, because this is what kills you. You don't usually die of anemia. You die of thrombosis. So we got to manage that. But, woo, 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 new sexy drug, eculizumab. Very sexy. All the drug companies are pushing it, so the USMLE likes it. Now, when a drug ends with MAB, we know it's a monoclonal antibody. It's a monoclonal antibody against complement 5. It's against C5. Okay, so let me repeat. It's a monoclonal antibody against complement C5. Remember the membrane attack complex? The membrane attack complex is C5 through C9. So if I make an antibody against C5, no membrane attack complex, it's not going to kill my red cells. So this treatment is very, very effective because it knocks out complement. So this is good. Knocks out complement. So now you're going to get less anemia and less thrombosis. So less hemolysis and anemia and less thrombosis. Here's the problem. This is one of the most expensive drugs on the market. It's one of the most expensive drugs there is. It's incredibly expensive. I don't remember how much, but it's like thousands of dollars for a treatment. That like $10,000, $20,000 for a drug? It's incredibly expensive, right? But it's on the exam. On the exam, we don't care about expense. Okay, so eculizumab. Now I need to know something. If you knock out C5, you knock out complement. You knock out the membrane attack complex. So what infection am I worried about? Jose knows. What infection am I worried about? Neisseria is gonna run rampant. So before I give you this, I might want to vaccinate against Neisseria meningitidis. Got it? So that's very testable. Before I give you this drug, I will vaccinate you against Neisseria meningitidis. Now, you can still get Neisseria gonococcus. All right? So they're still at risk for Neisseria, but you try to limit that risk by doing the vaccination. And that is so testable. So testable. So monoclonal antibody against C5, knock out C5, you knock out the membrane attack complex. Now you're at risk for Neisseria. It's good stuff. Very sexy. All right. Only 1 or 2 diseases left. G6PD. Everyone and their brother knows this one. G6PD. This is an X-linked recessive disorder, so it's going to be males. And the problem here is you can't regenerate your antioxidant for a red cell. What protects the red cells against oxidants is glutathione. If I can't regenerate it because I don't have the enzyme G6PD, now my red cells don't have protection. Oh no, no protection in red cells. So if I eat an oxidant food like fava beans, take an oxidant drug, or if I get infection and I create a lot of oxidants, I will get an episode of acute hemolysis because I don't have protection. Makes perfect sense. All right, now there's various forms of stresses. All of these oxidant stresses will lead to hemolysis because they don't have protection. To cause an episode of hemolysis is an infection. Everybody thinks it's fava beans. Nope. Everybody thinks it's sulfa drugs. Nope. Infections are the most common thing to cause a hemolytic anemia in G6PD. But of course, they'll ask drugs too. Drugs, not as common, but they like it. All the sulfa drugs. So dapsone, trimethoprim sulfamethoxazole. They love the sulfa drugs. Anti-malarial drugs like primaquine. As I mentioned, dapsone, that's a sulfa drug. Quinidine. There's so many drugs that can do it. But the one I really want you to remember is anti-malarial and dapsone. They really like these two, anti-malarial and dapsone. Okay, so I put patient on dapsone for pneumocystis prophylaxis, and next thing I know, they get anemia. So dapsone's used for pneumocystis treatment. You get anemia, it's G6PD. All right, now, again, patients look normal until they're exposed to the oxidant. When they get the oxidant, they'll get an episode of hemolysis, and it's going to be sudden. Sudden severe, usually takes about a day, sudden severe intravascular hemolysis. So you're going to get jaundice, you're going to get dark urine because of hemoglobin, you're going to be weak and tachycardic like all anemia. Now look for that history of drugs or fava beans. Look for that history. All right, now for intravascular, we talked about LDH, bilirubin. The retic count for all hemolytic anemias will going to be high. MCV is usually normal, haptoglobin's low, hemoglobin is also in the urine. Now, the best test here, the best test, definitive one, is the enzyme level. Get the enzyme. If G6PD enzyme's low, you got your answer. Here's the problem. You can't do it after the hemolysis, because all the cells that had low enzyme died. All the ones with low G, they all died. The only cells that are left are the ones that have normal G6PD. So after hemolysis, if you measure the G6PD level, it's going to be normal. So we can't measure the G6PD enzyme level right away. We got to wait. Now, usually we wait a few weeks, so 1 or 2 weeks, and then we do it again and do the test again in a few months, because it sometimes takes time to see that the G6PD is low. You got to wait for the cells to get old before the level drops. Okay? So again, the key is you can't do G6PD level enzymes at the time of hemolysis because it may be falsely normal. Measured a few weeks or a few months later, and you will see G6PD enzyme deficiency. Now, some other tests we can do. On a blood smear, we can look for Heinz bodies and bite cells. Here's the problem. They're not 100% diagnostic. They're a great clue, but enzymes, G6PD enzyme level, that's the definitive. But still pretty good clue. Heinz body is all the hemoglobin that gets oxidized. It sticks together and makes these bodies. We call them Heinz bodies. They're precipitated hemoglobin. Now, here's the problem. You can't see a Heinz body on a normal blood smear. You want to see my sexy body? You got to give me something special. You want to see my sexy body? You got to give me something special. You got to give me a supravital stain. Does this look like a red cells? They're not even red. This is a normal blood smear, right? This is a fancy stain. This is called a supravital stain. So I'm going to write a couple of names here that you might want to just get in your brain. Supravital stains. They're pretty special. They're going to help. Oh, I spelled it wrong. Supravital stains. They're pretty special, and they're going to help me see these Heinz bodies. So some examples would be crystal violet, and another example would be methylene blue. So here's some examples. Supravital stains are things like crystal violet or methylene blue. Listen, I'm just going to cheat. If you give me a blood smear and it's a fancy stain, sexy bodies. It's going to be Heinz bodies. Now take a look. Do you see these purple dots here on the membrane? Do you see the purple dots? That's the sexy Heinz body. See a little purple dot? Here's another purple dot. It's a kind of bluish purple. Here's another one, purple dot. See it? That's not malaria. No, that's not malaria. This is the Heinz bodies, the denatured hemoglobin. Now, when the spleen bite, you'll see bite cells on the regular smear. See the way it looks like the spleen took a bite out of that one, took a bite out of that one? Yeah, so on the regular blood smear, you'll see bite cells. Only on the special stain will you see the Heinz bodies. Now, here's the problem. Any unstable hemoglobin will make Heinz bodies. So do you remember a hemoglobin called Bart's? Together, dope, Bart's, dope, Heinz bodies. Do you remember hemoglobin H? That was unstable as well. Hemoglobin H will also give you Heinz bodies too. So Heinz bodies, I always think G6PD, but remember, thalassemias, the severe ones, can do it too. Okay, so it's not 100%. Great clue, not 100%. Bite cells, great clue, not 100%. Okay, so get the enzyme level. Enzyme level is 100%. Okay, all right, now what's the treatment for this? Well, you want to hydrate them so that the hemoglobin doesn't kill the kidney, right? Because all that intravascular hemolysis. And then if you get really bad episodes of hemolysis, you may have to transfuse. They get really anemic, you may have to transfuse. The key is avoid fava beans, avoid oxidant drugs. No more sulfa drugs, no more permaquin, no more dapsone. Avoid the things that cause hemolysis. That's it. That's what you do. Avoid the things that cause hemolysis. If you get a crisis, you may have to transfuse. Make sure you give fluids so the kidney doesn't fail. All right, last anemia. Last anemia is called aplastic anemia. Okay? Are you guys okay? Are you guys okay with that? Are you guys okay with that? Are you guys okay with that? Who am I? Are you guys okay with that? Are you guys okay with? Who am I? I love him. Isn't he so cool? He's awesome. That dude is cool. Yeah, I love him. He's really good. Really, really good. So yeah, you're getting some really good teachers here. He's like a chairman, man. He's like so powerful. All right, now last one is aplastic anemia. Aplastic. All three cell lines are no longer being produced. All the cell lines. So you're going to have red cells, that's anemia. You're going to have white cells, that's leukopenia. And you're going to have low platelets, that's thrombocytopenia. Now, when all three are low, we give it a fancy name. We call it pancytopenia. Okay, because the bone marrow is not working. So all the cells are failing. Now, when you look at the bone marrow, it's empty. Empty. It's aplastic. Makes sense. So you got a pancytopenia with a hypocellular marrow. Hypocellular marrow. Got it? All right, very important. Pancytopenia with a hypocellular marrow. That's your definition. Now, what the heck killed your marrow? Could have been radiation. You could have got radiation exposure, killed your marrow. Toxins, they love benzene. By the way, benzene doesn't just cause aplasia. It also causes leukemia too. Benzene and acute leukemias. Okay? What else? Drugs can cause it. You can have reactions with NSAIDs. Chloramphenicol, that's a big one for aplastic anemia. Of course, chemo drugs. Of course, chemo. Everybody knows chemo kills your marrow, right? You give too much chemo, you kill your marrow. Makes sense, right? Alcohol. All these can do it. Of course, infections. The famous one is parvovirus B19, right? That's the famous one. But lots of viruses, HIV, CMV, Epstein-Barr, these can all affect your marrow and cause aplastic anemia. And then I have the parvovirus B19. Now, again, all three cell lines are deficient. So, from the platelets, we should expect bleeding. From the red cells, we should expect all fatigue, tachycardia, angina. For the neutropenia and lymphopenia, we expect infections. Okay? So it makes sense. Low red cells, white cells, and platelets, you're going to come in with bleeding, infections, and anemia. Now, clinical presentation, it's not sufficient to determine true plastic anemia because what else can present like this? What else can present with a pancytopenia, doctor? What else can give you pancytopenia? What else can kill your marrow? Could be a cancer in there. Could be leukemia, excellent. Could be myelofibrosis. You bet. It could be a cancer, myelofibrosis. It could be a metastatic breast cancer, killing the marrow. It could be anything in the marrow, any infiltrative disease. So by itself, the clinical is not good enough. I gotta do the marrow to make sure there's no fibrosis, to make sure there's no leukemia. I gotta do the marrow to confirm. Okay? So again, the symptoms are telling me anemia, thrombocytopenia, leukopenia. Then I'll get the CBC. I'll see all the cells are low. Everything's low. Okay? Then I'm going to have to do the bone marrow to find out why. I'm going to do the bone marrow, and that will be the confirmatory test. Because it will show me there's no cancer. There's no myelofibrosis. It's just hypoplastic marrow. So basically, I'm seeing lots of fat and very few precursor cells. But notice, no leukemia, no tumor, because that wouldn't be aplastic anemia then. It would be a tumor-induced killing of the marrow, right? So aplastic anemia, it's not usually due to a tumor, okay? It's just happening. All right, now, how are you going to treat aplastic anemia? Well, if it's mild, you try to stimulate what's left to grow. So you give growth factors like erythropoietin, try to stimulate the red cells, try to stimulate the myeloid cells, filgastrum, you try to stimulate it, right? Now, if it's severe cases, you're going to do a bone marrow transplant. You got no marrow, try to give you new ones, okay? Now, this is done when patients are young and able to stand it. So when patients are young and healthy, we'll do allogeneic bone marrow, and it will cure up to 80%. But what if it's severe and you're not young? Oh, if you're not young, well, then you're going to do immunosuppressive therapy, because we think the majority of cases are due to the autoimmune phenomenon. Idiopathic, we think it's autoimmune. We think your T cells are killing the marrow, okay? So again, unless we know a cause, if it's due to drugs, great, we'll know it's the drugs, we'll stop the drug. But if we don't have a cause like parvovirus, we don't have a cause, it's probably idiopathic, which means autoimmune. That's usually what it is. So if I can't do a bone marrow replacement on you when it's severe, well, then what I'll do is immunosuppression. We try to knock out the T cells by giving anti-thymocyte globulin. Knock out the T cells with cyclosporin and, of course, prednisone. And this can lead to remission in a large number of patients. Okay, but again, this is for severe forms. Mild forms, we try to stop the cause and let the marrow come back. Severe cause, we have to do something. Okay, that's aplastic anemia. Excellent. Now, here is my email. I gotta keep in touch with you guys. I want you to feel supported. So I have low self-esteem. So on the exam, if you get some anemia questions right because of what we did tonight, I want you to circle it and say Barone rocks. So my email is baronerocks@gmail.com, because I'm a G and I'm a male. Now I also made a website. It's called baronerocks.com. It's got step 1, step 2, step 3. It's all mixed together. So if you ever need a mental break, go check out the website. It's kind of fun. So we got a few minutes left. I want to do a quick review. Quick review. Ready? Please tell me. Just yell it at the screen. You don't need to type it. Don't need to type it. Ready? Quick review of everything we've done. If a patient has anemia, we cannot tell what it is by the symptoms. So what is the first test for all people who look like they have anemia? Just yell it out. First test for all things that you look like anemia, smell like anemia, CBC and blood smear. CBC and blood smear. Look at the H and H first. If the H and H is low, it's anemia. Then you look at the MCV. Okay? What is the best test for a low MCV? Yell it at the screen. Best test for a microcytic anemia? Iron studies. Just yell it. Iron studies. Iron studies. Iron studies. What is the best next test for a normocytic anemia? Normocytic. Oh, that was the hard one. Get the babies. Get the babies. Get the babies. The retic count. Because if the retic count's low, it's a bone marrow problem. If the retic count's high, it's hemorrhage and hemolysis. Okay, what was the next test if it's a high MCV? High MCV, it's megaloblastic or full, or it could be alcohol. Why don't we get the blood smear to look for hypersegmented neutrophils? Then we can look for B12 and folate next. Excellent. Okay, if I tell you the ferritin is low, what's the answer? Ferritin's low. How easy is that? If ferritin is low, you're iron deficient. It's like a giveaway. If it's a 2-year-old, do a Meckel scan. 2-year-old, do a Meckel scan. If it's your and my age, you want to check for peptic ulcers. And in a woman, you want to check the menstrual period. If they're over 50, check the colon, check the colon. Iron deficiency over 50, check the colon. All right, now the best initial therapy is oral iron. If they're having malabsorption due to acid, add ascorbic acid. All right, now what if they really can't absorb it? Then you're going to do IV, parenteral. IV parenteral. What is the most effective way to give iron that we don't really do? Transfusion of blood. Blood transfusion, we don't do it, but it'll be the most effective. Good. All right, now please tell me, what are you going to do if I tell you the ferritin is high, but the serum iron is low? Storage is high, serum is low. I got it, but I'm not releasing it. I got it. That's the anemia of chronic disease. Anemia. Treat the chronic disease. Treat the chronic disease. Excellent. Treat the chronic disease. Excellent, excellent, excellent. Let's see, what else? What if I tell you that it's a microcytic anemia and the iron panel is normal? Normal iron panel, microcytic with a normal iron panel, that's thalassemia. That's thalassemia. Yeah. So what test do I do next? I think it's thalassemia. What do I do? Electrophoresis of the hemoglobins. Oh, I find hemoglobin H. Oh, that's alpha thal, 3 genes deleted. That's hemoglobin H disease. Hemoglobin H, 3 genes deleted. 4 genes deleted, you're dead. That's hemoglobin Bart's. 2 genes deleted, you look normal. You got a trait. Avoid stress. All right, now let's talk about this one. What if I tell you I got lead poisoning and basophilic stippling, and I have anemia? Anemia. So, board question. What is the most accurate test? Most accurate test for sideroblastic anemia? Prussian blue of the bone marrow. Look for the ring sideroblast. Look for the ring of iron, Nemo. The ring of iron. The ring of iron, Prussian blue. That is your most accurate test. Now, how are we going to treat it? Treat the lead poisoning with chelators. If it was due to B6, give B6. B6, right? So if you know the cause, treat the cause and try B6. Try B6. Good. You guys are awesome. Let's try the next one. Next one we need to know. Please tell me. MCV is increased. MCV is increased. It's sky high. We see hypersegmented neutrophils. Hypersegmented neutrophils. What is the most accurate test for B12 deficiency? A B12 level. B12 level comes back normal, but you still suspect. They got neurologic, you think it's B12, but B12 level's normal. But they got neurologic, you think it's B12. Methylmalonic acid. That would be your next step if the B12 comes back normal. You still think it's B12, methylmalonic acid. Okay, what is the next test you're going to do once B12 is low? What's the next test to confirm the most common cause is pernicious anemia? What's the next test you do to confirm pernicious anemia? The antibodies. Just yell it at the screen. The antibodies. Antibodies against intrinsic factor. Now, if that is equivocal, you might do a Schilling's test. Schilling's test will correct with intrinsic factor. That's pernicious anemia. But again, you don't have to go that far. Antibodies is usually good enough to make the diagnosis, but we went to Schilling's anyway. All right, now question. What if I tell you a patient comes in, they have an episode of hemolysis, they have, let's see, on blood smear, they have sickle-shaped cells, and they ask me, what will be the most likely cause of death in this person in the future? Most likely cause of death in the future? What are they going to die from? Well, obviously it's sickle cell, right? So what are they going to die from? Strep pneumo. #1 killer, acute chest syndrome, it will be up there too. They'll be #2. So make sure you vaccinate before they lose their spleen, right? Make sure you lose the spleen. Now, what if they have sickle cells and they tell you there's hip pain? Hip pain in sickle cell? What will be the next step? avascular necrosis. Now, it could also be osteomyelitis, and MRI would pick that up too. Usually if you think it's osteomyelitis, usually get an x-ray first. X-ray first. If x-ray is indefinitive, you get the MRI next. Okay, good. So MRI can pick up either avascular necrosis or osteomyelitis due to salmonella. All right, now what if the sickle cell patient suddenly gets anemia with a low retic count? Anemia with a low retic count? Sickle cell? Anemia with a low retic? You got to think about aplastic anemia due to parvovirus B19. Now, I forgot to ask you, what is the most accurate test for diagnosing parvovirus B19? I forgot to tell that to you. What's the most accurate test? Is it the bone marrow biopsy? Is it IgG and IgM against parvovirus? Or is it PCR for parvovirus? Is it bone marrow, IgG and IgM against parvovirus antibodies, PCR against parvovirus DNA? Yeah, PCR is always going to be best, right? The PCR test is the most accurate. Now, I'm going to do them all. I'm going to do a bone marrow, look for inclusions. I can do IgM and IgG. That's kind of cheap to do. But ultimately, PCR is your most definitive test. How do you treat the parvovirus aplastic crisis? How do you treat parvovirus aplastic crisis? Isn't this fun? You feel like a doctor. How do you treat parvovirus aplastic crisis? We'll transfuse so they don't die of anemia. But how do you treat the parvovirus? You give immunoglobulins. Immunoglobulins. That's all you can do. Immunoglobulins. So you give transfusions for the anemia, and you give antibodies to try to lessen the infection. You give immunoglobulin therapy. That's it. IV immunoglobulins. I know. That's the only treatment for parvovirus B19. Usually it goes away on its own. Just give antibodies until then. All right. What is the only known cure for sickle cell? Only known cure? Only known cure? Bone marrow transplant. Bone marrow transplant. What is the treatment of choice? The treatment shot, the gold standard for beta thalassemia major. Cooley's anemia, beta thalassemia major. Same thing, bone marrow transplant. So sickle cell is a bad disease, you consider bone marrow. Beta thalassemia major is a bad disease, consider bone marrow transplant. Okay? What do you give a sickle cell patient if they're having 4 or more crises a year? 4 or more crises a year, what do? Hydroxyurea to increase fetal hemoglobin. Excellent. Okay, tell me the best test for paroxysmal nocturnal hemoglobinuria. Best test for PNH. Flow cytometry. What was the name of the test though? Yeah, the FLAIR assay. The FLAIR assay, which is done by flow cytometry, you were right. FLAIR assay, done by flow cytometry, and it looks for GPI. If that's not a choice, then you do flow cytometry looking for CD55 and CD59. CD55, CD59. Good. What was the drug you're going to use for severe episodes of thrombosis? Do you remember the drug for severe thrombosis? Very expensive? Yeah, eculizumab. Problem is you could get Neisseria from it. You could get Neisseria. All right, question. What if I tell you patient comes in with cyanosis in their fingertips and cold. Fingertips and they're blue. Well, you got to think about cold agglutinin, IgM, right? IgM. Where is it being destroyed? Well, IgM's only sticking the cold, then the activate complement, then it gets destroyed in the liver. So is splenectomy going to work? Nah. Steroids going to work? Nah, doesn't work. So avoid cold and rituximab. Avoid cold, and if it's more severe, you give rituximab. Rituximab. Knock out the B cells. Knock out the IgM production. Make sense? Good stuff. And by the way, if it's even worse than that, you may use alkylating agents to try to suppress your immune system even more. Okay, usually you don't have to get that far, but pretty cool. Okay, please tell me, what is the best test for distinguishing autoimmune hemolytic anemia from hereditary spherocytosis. The direct Coombs test. All right, now please tell me, did we cover a lot of material tonight? Yeah, we did all of anemias in one day. We talked about differential. We talked about telling things apart. We talked about first test, most accurate test. We talked about treatment, what to do first, what to do second. You're now prepared for step 1, step 2, and step 3. You're in really good shape. Now, tomorrow we got a lot more to do. We got to do the leukemias, lymphomas. Got to do the stuff like that. With some bleeding too. We should do bleeding as well. So I'm going to see you guys tomorrow. Have a wonderful night, and thank you so much for spending your time with me. The most important thing you have is your time, and you spent it with me. I'm honored. So I wanted to get you as many points as I could. Have a wonderful night. I'll see you tomorrow. Thank you, Amal. Thank you, Mark. Thank you, Maggie. You got a great tech team here. They're awesome. They're going to answer all your questions. Have a great night. Hang in there. We'll get them tomorrow. Take care. Oh, thank you, guys. Nice comments. Thank you.